Hi Ritu.
Hello, good evening, sir.
Is my audio clear?
Yes, sir. Yes, sir.
एक बार स्क्रीन शेयर ट्राई कर ले right now if that's okay.
Dr. Vidur Mahajan.
Hi, sir. How are you?
I am Dr. R.V. Ashokan, Secretary General of IMA.
Nice to meet you, sir. Thank you so much for having me.
It's an honor to have you, sir.
Arey, come on, sir. Please, please. Not at all.
Yeah. And we have been conducting these webinars ever since the pandemic started,
sir,
to understand different dimensions. And Dr. K.K. Agarwal is our resource person.
Yes.
What we normally do is that even though the invited guests for this particular one directly will be less, we put them all in the website.
Sir.
And they are accessible for our members for further study at leisure. That's it's available for all the IMA members. It's put all our 26 webinars are on the IMA website.
Wow.
So it will be of great use to the fraternity throughout the country.
No, great, sir. I'll try to do my best.
Yeah, you are welcome, sir. You are welcome to IMA. We are waiting for Dr. KK.
He's already there.
Oh my God!
Sharp 4 o'clock, and I'm there.
Yes.
Sir, you are in pink today.
Yes, changes. Today is Navratri, the first Navratri. First Navratri is a white dress, so that you are wearing, and the white dress with the red border that I'm wearing.
Great.
So I kindly request Dr. KK Agarwal to start the proceedings of the webinar.
Are we live, Ritu?
Yes, sir, we are live.
Yes. Hello, everybody. Greetings from Indian Medical Association and Confederation of Medical Association of Asia and Oceania. I'm Dr. KK Agarwal. We welcome you all to this seminar of IMA, which is 24th seminar. Sorry. 28th seminar.
28th.
So this is 28th seminar of IMA. Due to some reason, my mistake. And for me, it is 862nd seminar, which we are doing. And the basic objective is we have been talking to people on various grounds. And now we want to go higher and higher up. And now we want to understand the importance of AI. Corona has taught us one thing, and that is Western countries may not be the great. I'm not naming a particular country. The Western countries are no more great. And Corona started with zero for everybody. Now it's a time for India to go beyond everybody and take a shape. And one of the field where the West tries to overtake us is AI, but only because of the Indian brain working there. So we thought of inviting Vidur, who is with Mahajan Radiology Imaging. I have seen him a couple of presentations in FICCI and other places, working extensively in the field of building up an AI in imaging of COVID. If they succeed in their software, a time will come where you go to that site, put up your CT scan or an X-ray, and it will give you an automatic diagnosis. It may give you an automatic inference. It may tell you that whether you are recovering or not recovering. And if that happens, that will be the first AI software developed in India. So that's what, so we wanted to understand basics of AI. So I present to you Dr. Vidur Mahajan.
Thank you so much, sir, for this opportunity, for that introduction, and certainly, us along with multiple collaborators are trying to, crack this conundrum of diagnosing AI, diagnosing COVID using AI, and then many other things. Sir, with your permission, may I share my screen? I have put together a few slides just to, bring everyone on the same page. I'll just. Sir, is my screen visible?
Yes.
Great. So basically, the idea is the topic also that was given to me was AI in what I took the liberty of saying hashtag COVID times. These interesting times that we are living in. And my goal of this, of the next 20, 25 odd minutes is to give you an overview of what AI is. I think it is very important for everyone, especially healthcare professionals, medical personnel, clinicians, to know what AI is and what possibilities it presents. And so I will take you through almost a laundry list of examples of how AI is impacting COVID, so that the end goal being that you should be able to think of newer innovations, newer ways to improve your practice using this beautiful tool that I will also go a little detail I'll also go into a little bit of detail with. Um, so I'll start by introducing Caring. Caring is the Center for Advanced Research in Imaging, Neurosciences, and Genomics. It is what I run specifically within Mahajan Imaging. It's the R&D unit of Mahajan Imaging. I will just proceed quickly. We have two divisions. First is our AI research division, which is called Carpal, the Caring Analytics platform. And the other is our genome sequencing division, which is called Caring DX. And more recently, we have started doing a lot of COVID testing and COVID-based sequencing in this division. This is the team. We are a team of clinicians, engineers, data scientists, molecular biologists, sitting together in now one virtual room, trying to answer some of these questions around taking products from, as they say, bench to clinic. These are our collaborators. We work with MIT, Max Planck Institute, Harvard Medical School, IIT, Triple IT, you name it. And it's if they are working in the domain of AI in healthcare, there's a high likelihood that we are working with that group as well. And these are all of our industry collaborators. We value their support and trust to a great degree. Building research credibility is critical for us at Caring. We were lucky to have published the first paper on deep learning in the Lancet. This was the first time ever that there was a peer-reviewed research paper of that stature, and all of the work happened in India. So, to Dr. K.K. Agarwal's initial point of Indian brains building Indian technology, the first paper in the Lancet on AI was from India. So, I think that goes to say a lot about our capabilities in this country. Then, we have published extensively on regulation, on opening up, on transparency in AI, auditing AI, various things over the past few years. And then, we present prolifically at academic conferences. These are all the papers, more than 90, that we have presented in academic conferences across the world. And then we have won a lot of awards and got some recognition. All of this, or most of this, in the domain of AI. And we also publish posters. This was at the Radiology Society last year, where a lot of the work we published was on testing AI. So this literally, the title goes, "How to Lie with Statistics: Things to Keep in Mind While Evaluating a Deep Learning Claim." And these things are becoming even more relevant today, because in our hashtag COVID times, we are seeing a lot of claims from all over the world about amazing kind of things that technology can do. So how do you evaluate those things? So this is just presenting some of our work. Now, getting to the topic at hand, what is artificial intelligence? It's not a new concept. I think that is one of the key things everyone has to realize, is that the algorithms that are being used for AI today actually date back to the 1950s, where the mathematical capability existed, but the computing capability did not exist. And because of that, we are now seeing this, almost resurgence of AI because of several things which I'll just get into. But effectively, AI refers to the ability of computers to learn without being explicitly programmed. So instead of telling a computer what to do, The computer figures it out itself. That is the key concept behind how we look at AI today. And why has it gained recent popularity? Because our smartphones, this phone, is more than 10 million times more powerful than the computers that sent Apollo 11 to the moon. So that is the extent of power that we now have literally in our hands. And then there is a new approach called deep learning, which we will go into a little bit of detail on, that has widespread implications and applications. And both of these things, increase in compute power combined with the novelty of deep learning, have led to AI being everywhere. But the best definition of AI that I could find that actually stands the test of time is AI is whatever machines can't do yet. And this, I picked it up from Wikipedia. There is this theorem called Tesler's theorem, which is basically this statement. And this is very interesting because if you think of it, if somebody from today would turn up with a calculator, our simple accounting calculator, if someone would turn up with that in 1956 and say that, I have a device that can do 5,324 to the cube root in half a second till 10 decimal places, people would have gone mad. It would have been the epitome of human intelligence at that time. Today, it's just a calculator. We don't even think of it as being an intelligent device. So the definition of intelligence and thereby the definition of artificial intelligence keeps changing to the extent that whatever machines are not very good at right now, we think is AI. And as soon as it becomes simple for machines to do that, we stop thinking about those things as AI. And I present two examples on that. Google Maps is possibly one of the most sophisticated AI tools on our planet today. But most of us don't even think of it as AI. We just think of it as a tool, right? I have to go from point A to point B. I put my destination into my phone. It takes me. That's it. There is no thought around what is the algorithm, what is the machine learning, system behind it. None of that. Similarly, I'm sure all of us use this feature on our cell phone keyboards, where the phone tries to predict what you are going to say next, and many times it's right, and we just click it and use it. We don't think that this is some fancy artificial intelligence algorithm or something like that. We just go ahead and use it. So the point I am trying to make is that we all use AI in our day-to-day lives. It is very much a part of what we do today, whether we are shopping on Amazon or watching a movie or calling an Uber or searching on Google. We are using the world's most advanced AI systems, but we just don't know. So that is the power of this technology in itself, and we are hoping that it comes to healthcare very, very quickly. So there are three types of AI. Very quickly, I will go through that. There is artificial narrow intelligence, which effectively refers to the ability of machines to do one thing very, very well. So, for example, this is the quintessential computer called Deep Blue that beat Gary Kasparov at chess almost about 20 years ago now. And but Deep Blue can only play chess. It cannot do anything else. It can't play any other game. You can't have a conversation with it. It cannot tell you, like Google Maps, the point A from point B thing. It only does chess. And this is where machines are today, right? Google Maps can only show you the way from one place to another. Google search can only help you search. So machines are currently artificially narrowly intelligent. So they are intelligent, but in one domain. Then there is this concept of artificial general intelligence, AGI is what it's called, which is basically the concept of a machine learning to do one thing and then extrapolating that wisdom to another. So, for example, human beings. We are all generally intelligent in varied aspects. We may be very good at one thing, not very good at another, but reasonably all of us can walk, talk, sing, dance, have a conversation, those kind of things. And then we specialize in a few things. So humans are generally intelligent. Machines currently are not generally intelligent, but there are a lot of work going on in this domain right now. And now there are machines that can automatically learn to play games with human beings just by observing humans playing those games. So chess, shogi, go, etc. These games are in the domain of AI, wherein AI systems simply learn these games themselves. They learn the rules also themselves. And then we have artificial super intelligence, which is a very, very debated topic, which basically says that what happens when machines are narrowly intelligent generally. So machines are narrowly intelligent in every aspect of the world. And that is, this divided future of machines taking over the planet and all of that, which I don't think it was going to happen anytime soon. There are also two broad categories of AI applications. I would urge you to, think of such categories whenever you are posed with an AI application. If some company ever comes to you, or some IT person comes to you, and they try to propose a AI solution, you can broadly bucket them into these two categories. The first is things that humans can do, but machines can either do better or faster. So, for example, looking at a CCTV camera footage, like we humans can do it. We can look at 4, 8, 16 maybe cameras at one point. Machines can look at millions of cameras simultaneously, right? We all know that, in many countries across the world, there are surveillance programs, etc. In fact, even in the COVID context, CCTV cameras have been used for doing things like proximity detection, etc. So machines can do, humans can do it. Of course, there's no debating. Humans can definitely do it, but machines can do it much faster. And then the second example is of Google Translate, where it effortlessly translates from one language to another, which is again something that humans can do, but we can't do it at a rate of 1 book per second or something like that. So just keep this framework in mind. The other task is things that humans cannot do, and I will go back to my Google Maps analogy to say that there are certain applications like telling the exact time it will take to go from point A to point B in the most optimized way that human beings just cannot do, because there are too many variables and there is too much information to be able to make this decision and take this call. So just keep that in mind, and then realize that these tasks are typically not magical, right? Because we have a benchmark. It is something that humans can do. So we always know that, okay, the machine is going right or wrong because we have a benchmark. So I categorize these as not magic, whereas these kind of categories are essentially magic. And we will go into this, a little bit as we talk about applications of AI in COVID. Going on, you may have often seen that, in any newspaper article or academic article, they talk about a AI system was trained on 100,000 chest x-rays, for example. So whenever they say that, it basically means that the technique in question is deep learning. And generally, deep learning is as I had mentioned earlier, one of the reasons why AI is so prevalent nowadays. And the amazing thing about deep learning is that in conventional machine learning or image processing, if you were to teach a machine how to figure out what these digits are, right? So this is a 5, this is a 0, this is a 4. If you were to teach a machine how to figure out what a 0 is, you will basically say that anything that looks like a circle is a 0. Anything that has one short line, one tall line connected by a horizontal line is a 4. Anything that is, a single line is a 1. So we would have to program the machine to be able to figure out these things. With deep learning, all we have to do is give the machine 5,000 examples of 5, 5,000 examples of 0, 5,000 examples of 4, and so on. And the machine itself figures out these patterns. The machine itself will figure out what exactly is it that the number 4 refers to, or the number 3 refers to. So machines figuring out patterns themselves. And this is where most healthcare AI is today, where you give a machine a lot of data and the machine itself figures out a pattern in that data, and then you test that data algorithm independently. The other technique is called unsupervised learning, which is what human beings are. Nobody really teaches us how to walk. Nobody really teaches us how to, teaches this baby how to hold something. We automatically learn from our environment. And this is where, again, most of the cutting edge work in AI is on unsupervised learning, where can machines learn things without even being trained. Right. And I will not go more into detail, but basically, this is where human beings are. And this is one of the fundamental differences between human beings. So classical example is that, let's say a radiologist does not need 100,000 X-rays, does not need to see 100,000 X-rays to be able to figure out, which X-ray has pneumonia and which does not. Because, we are unsupervised in our learning mechanisms, and we can transfer knowledge from one aspect to another. So whereas with machines right now, you need to do that. Moving on, how is an AI algorithm created? Very, very quickly, it has to start with finding data. So I've said this many, many times now. The first thing you need is a data set which is very clean and very heterogeneous. So you need to cover most instances of what you are expecting the algorithm to see. So, it could be 100,000 CT scans, 100,000 chest X-rays, 100,000 clinical outcomes. It can be anything, or 100,000 lab results, but it has to be a lot, and it has to represent the diverse spectrum of disease or finding that you are trying to get. Once you find this data, you train a model on that data. So you tell the AI algorithm that, okay, this is all of my data. Now you figure out what separates a normal and an abnormal chest X-ray, for example, or a normal and an abnormal ECG. And then the machine figures it out. Then we validate the model. So we validate the model on whatever data is left with us. And this is then an iterative process. Train, validate, train, validate, train, validate, till the time that you get to a situation where you are now satisfied with the performance of the AI, which is when you test the model in an independent setting. So let's say the model was created with data from my hospital. I will now take that model to the hospital across the road and run it there and try to see, does it work as well as it did. So this is the broad journey of how an AI algorithm is created. We can go into infinite detail, but we'll stop for now. Now coming to AI in hashtag COVID times, right? But before the AI part, one of the biggest boosts for AI that we have got during these times is that COVID has driven the adoption of digital health tools. And these are just, 2 examples. And I'm sure everybody, IMA, any practitioner of medicine across the world actually now would have benefited from telemedicine during these times, right? There are clinicians. Yesterday, I heard Dr. KK Agarwal himself say that he has a patient in Bombay. During normal times, these things are unheard of. But COVID has driven the adoption of digital health to such an extent that it is now routine. And the Ministry of Health also came out with telemedicine practice guidelines. The government came up with this e-Sanjeevani portal, which is basically for the government facilitated telemedicine consults. Insurance companies are now talking about reimbursement for telemedicine. So very, very exciting time to be in digital health. And, COVID has driven it to a great degree. And we hope that it sustains. Now, the great thing about digital health is that most things start getting digitized. So most records start getting digitized in some form or the other, which is why just the digitization of healthcare is a great push for artificial intelligence as well. Moving on, I decided to not focus primarily on diagnosis, which is like our core focus, but to actually give you a glimpse of how COVID is helping in the or how AI is helping in the war against COVID across the entire landscape. Right, so all the way from prevention to diagnosis to therapeutics of COVID, AI is everywhere. And I will show you some examples. Maybe in some instances, you may not have known that there are AI algorithms at play. And that might be very, very interesting because there are many non-obvious uses of AI that are out there that are impacting our life every day. So I'll quickly jump in. So public health decisions are being driven by AI-based techniques across the world. So, for example, the government of Delhi worked with Triple IT Delhi, a lab run by Dr. Tav Pritesh Sethi, to actually try to, drive the decisions around which areas to lock down and which areas to open up using AI. Also, things like how much to test, how much, because there was this phase where Delhi government was testing extensively, then they shift to rapid antigen, then they stopped. Now they're doing RT-PCR again. So there is a fair bit of science and data analytics that goes behind it, and anyone who's interested in playing with these tools can go to this URL, which is covision.tavlab.triple-it, and try to play around with these things. This is a very nice projection of, they have taken various machine learning models and made it all clickable, that you can click through, you can say, okay, what if testing was so much and tracing was so much and lockdown was there, lockdown was not there. Various scenarios you can plan yourself, and there is AI at the back end that will present to you various insights on the same. Then we have, this is a company very closely associated with us called Cure.ai, based in Mumbai. They created an AI-based contact tracing and case reporting platform. So it was very much like Arogya Setu, but they created it, and I know that they are in conversations with various governments across the world at country level to deploy this. And again, it sounds very simple. It's an app into which you say, like, that is given to every COVID positive person. The app tracks the person. It will try to see if two people get close together, or if infected person is going into a non-infected area. And again, several algorithms at the back end that help drive these insights. The government, as I mentioned, the Arogya Setu mobile app has tremendous amount of machine learning behind it. We may not know it, we may not realize it, but the green, orange, and red marking for Arogya Setu also has a lot of risk characterization, etc. behind it, and all of that is modeling. All of that is machine learning at the back end. There are also apps out there, or there are also people are selling proximity bands, proximity sensors that you can wear and go to offices, and if two people ever come too close to each other, both of them get an alert that you should go far. So these are, again, this is not the most advanced AI algorithm, but it is a machine learning algorithm, and it is linked using IoT devices, and it is helping prevent COVID. So these are some non-obvious uses of AI that are out there. Also, this is a beautiful paper from IGIB, the Institute of Genomics and Interdisciplinary Biology in Delhi, where they helped the Kerala government figure out where their cases were coming from using machine learning combined with genome sequencing. Very, very interesting paper. And essentially, one of the key insights was that Kerala had a 21-day quarantine policy, which was the strictest in India at the time. And it worked because hardly any of the cases that they saw. So if you can see here, these are all of the various strains that they saw, and hardly any of the cases that they saw were from outside India, which was very, very interesting. AI tools are essentially are also an essential part of vaccine development. Again, coming back to the prevention aspect, in order to develop any kind of vaccine, you need to do a lot of review of literature. There is already an AI tool out there. In fact, it's been there now for almost 5 months, called Code 19, which is a machine learning indexed database of some 280,000 articles, where any researcher can go and use text-based machine learning techniques to sift through large amounts of data publications. Like imagine there are 300,000 publications on COVID already, or if not more. So, and many of them are indexed here. So using AI techniques to find literature to make the ideal vaccine. One, it's a very non-obvious use of AI, but it exists and it's important. Secondary, for molecular biology, in order to develop a vaccine, you need to look at the protein folding patterns. How does the actual interaction happen between the virus and the human cell? How does the immunogenic response happen, etc.? For that, Google released a tool called AlphaFold, which is basically using machine learning algorithms. This is the same team that created the AlphaGo, which I just mentioned, which learns chess on its own. So the similar algorithm is being used to predict how protein structures can interact with each other, and how potentially vaccines can impact the body. So this is also it's a in silico trial, if I may, of vaccines and other drugs. And lastly, when you put the vaccine into a clinical trial, who do you give it to? Where do these people come from? How much of the vaccine do you give? How many doses do you give? What is the genomics behind it? Because maybe my vaccine strain is of some type, but my patient still gets, or the person who's got the vaccine still gets positive for COVID. You need to use machine learning techniques to figure out, was it the same type of virus that the vaccine was primed on, or was it a different type of virus? So just again, very non-obvious but very amazing kind of tools, and many of these will fall into that domain of magic, right, where humans are cannot do. Like we just cannot parse through 280,000 articles and come up with summaries. So very, very interesting. Next, on the diagnostic front, I think it is one of the most well-known. Many of us would have seen headlines of chest X-ray being used to diagnose COVID, chest CT being used, other interesting applications. So we'll quickly go through this as well. On chest X-ray, diagnosis and triaging of COVID-19, Kyo.ai, again, the Mumbai-based company, they have a beautiful algorithm for it. Deep Tech is a company based in Pune. Lunit is from Korea. CoveBase is the initiative that we've been running in conjunction with IGIB, ICMR, and a few other collaborators. Just to point out, right, a lot of the COVID diagnostic work on AI is happening in India. And one reason is that, yes, we do have some of the smartest people on the planet. Second reason is many people are using AI systems that were built for tuberculosis and repurposing them to COVID. So, and because India is kind of the hotbed for TB, a lot of the AI focus was on TB in India. So that, gave us a unique kind of competitive advantage. And there are many, many global attempts. Like I'm sure there would be at least more than 150 papers already out there on X-ray for COVID-19. And where is this used, right? Because we all know that X-ray has low sensitivity for COVID diagnosis. COVID essentially starts as an upper respiratory tract disease, and an X-ray will only come positive for COVID if the person has pulmonary involvement. So it is best used in high suspicion situations and in resource constrained areas. So you don't have a place with a CT scan, you don't have an RT-PCR, at least do an X-ray. It's better than nothing, right? And the normals can be ruled out quite effectively. So good AI systems available. Many of these companies also can rule out normals very well. So at least, you can rule out the pulmonary, like the pneumonia versus normals, and then, triage accordingly. Additionally, this is the work that we've done in collaboration with CSIR. KK Agarwal sir was mentioning at the beginning, anyone can go to this website, covebaseforall.igib.res.in, and you can log into this website, create an account, and you can start uploading your own X-rays. It'll start giving you reports like this. So it'll give you COVID probabilities. It will try to make bounding boxes around where it finds consolidation. It does all sorts of measurements and various things. So it's constantly being tweaked. The algorithm, the latest algorithm is always available here, and our paper is currently under review in Nature for the same. So hopefully that comes out soon and we'll be able to share that with you. The other application of X-ray AI for COVID, which is much maybe more impactful, is the ability to monitor disease progression. So as you can see here, again, this is an indicative image from Cure.ai's algorithm. Using AI in a fraction of a second, you know that, okay, the level of pulmonary involvement has reduced in the image on the left to the image on the right. And this is especially helpful in situations where you may not have trained manpower in the ICU. And, if the technician, as he's taking the X-ray, just gets this notification, it helps short circuit the communication channel. And, in this case, the patient became better. But in a case, if the patient's becoming worse, it can help you intervene even faster. So, and it's low cost. All you need is an internet connection. And you can also quantify the lung damage and get it into percentage terms. So 2 applications of chest X-ray, right? Diagnosis and triaging, and disease progression monitoring. And it's also very heartening to say that many rural parts of our country have successfully implemented these tools and are using them even till today. So very happy to share that. COVID CT scan obviously has much better sensitivity because CT in itself is much better for the lung imaging than X-ray. And this is a tool by Predible Health. Again, another beautiful startup based out of Bangalore. Again, anyone can go to their website, covid.prediblehealth.com. You can upload your own CT scans and you can start seeing these CT severity reports. Automatically, ground glass opacities are labeled on the CT scan. And they are processing about 15,000 CT scans a month using this algorithm. And it's very helpful for pulmonologists, even for radiologists, because they don't need to do all the marking and all that and calculate CT severity scores, etc. But at the same time, non-radiological physicians, pulmonologists, general practitioners, internal medicine doctors also have a tool using which at least they can get something. And the interesting thing about Predible's algorithm is that they claim a 95% volume concordance. So what that means is when a radiologist calculates the volume of involvement of the lung by COVID, and the algorithm calculates there is only a divergence of 5%, which for a directional decision-making tool is really very good. And in the initially in the early part of the year, when RT-PCR tests either were just getting made or did not exist, AI played a very vital role. And this is a paper from China where they talk about how AI algorithms actually helped them in that time of crisis by at least, again, giving them a way of diagnosing COVID on CT scan, and again, sensitivity, specificity, etc. At least here, as compared to thoracic radiologists, the AI was very comparable. These are the receiver operator characteristics curves. The red dot is a senior thoracic radiologist, so he was better than all the algorithms. But the radiology fellow was worse than the algorithms. And if you see here, broadly speaking, an area under curve of 0.92 is very good. It's not bad. So that's why, in times when RT-PCR tests were not there, CT played a very, very, very important role. And the key thing is that they also took into consideration non-image information. So what is the clinical situation? Did the patient travel anywhere? What are their blood tests like, or lab tests like? So this was one of those seminal moments where, of course, the paper followed the work by several months, but in the absence of an existing test, AI served as a good use. And many more novel attempts are there at diagnosing COVID using AI techniques. One of the most interesting, although debatable, is diagnosing COVID-19 from cough sound. And again, debatable because not everyone gets cough. So, but people are trying to do this. This is a very good paper. Also, they describe the method in a lot of detail. And I think anyone can go ahead and download this app, if I'm not wrong, and try to see and try to contribute also to this database. And then there is work going on using routine blood tests. So the fact that there is neutropenia, lymphocytosis, etc. Can all of that be built into a machine learning model? And can you just input a pathology report and get an output of COVID from the machine? So these are just some of the diagnostic tools. We'll quickly cover drug development and drug repurposing, because again, this is one of those things where nobody really knows, but AI is at the front end here also. This is a very, very good review article in the Lancet. Anyone who's interested in this should definitely go through it. And they essentially talk about how the entire life cycle of a drug can be, the entire pipeline can be made very, very, targeted using AI. So because the objective right now for everyone is to bring drugs to market the fastest. And AI can help in that, from all the way from genomics to proteomics to organ level cell signaling. So all of these things can be done in silico. You can see the effect of various drugs on various drug targets in computer systems itself. And just one of the beautiful things that is possible with AI. With that, just a quick summary. There are more than 50 FDA approved healthcare AI products that are out there. So most definitely the future of medicine is in AI. There are hundreds of companies that are building AI tools for medicine. And I think it's time for doctors and clinicians to start today. There are many, many resources out there that you can use to start getting involved. Some courses, like this is a course I recommend for everyone, and it is also called AI for Everyone. Gives a very high level kind of insight into how AI works, and how you can use it in your day-to-day work. And of course, if you ever want, we are there for you, the caring team. And with that, I thank you for your attention, and happy to answer any and all questions.
Thank you, Vidhu, for an exhaustive introduction to AI for IMA. And I think it was a very good presentation. So I want to pick up some points. As on today, what are the websites or tools available for IMA members which you suggest? One for X-ray, one for lab, one for the CT imaging.
So for lab, unfortunately, there is no public one available right now. But for X-ray, there is, maybe I will just write it and put it up here. But for X-ray, they can go to Covebase for all. I'm just writing it, sir. And for CT, they can go to covid.prediblehealth.com. So these are the two. I'm just putting them up here also.
And do you suggest that the people should go for it? Doctors should cross-check
Of course, see, there are two elements to it, sir. One is if you are in a genuinely in a resource constrained situation, then most definitely these can help. The only thing is, sir, as in all radiology practice, you have to correlate clinically, right? If the AI system says that there is no COVID, but the person whose X-ray it is the husband or a wife of a COVID positive patient, then you have to include your clinical suspicion into the mix. So that is the disclaimer that goes with this, sir, because the AI as of now, whether it is CT or X-ray, is only looking at the images. It is only it is not taking other points into context while it gives its COVID probability. Because sir, we have seen instances of, so there is one company called Allengers, sir, I'm sure we would be familiar with their X-ray machines. So we put our, algorithm into their system, and, they exposed it to 3 or 4 COVID positive patients' X-rays, but the X-rays were visually normal, right? So any radiologist would look at those X-rays and call them as normal, and the machine also called those X-rays as normal. But the feedback we got was that these are COVID positive patients, and the machine called it as normal. So when we dug further, we found out that their family members were infected, etc. So their likelihood of having COVID would have been very high. So that's why, sir, these tools have to be seen in clinical context and not as isolated diagnostic modalities.
What I am basically trying is what long COVID or a post-COVID now
Sir,
is a known entity.
sir,
People
sir.
want to know the comparison, whether they are improving or not.
Yes,
So biochemically, we have a criteria of CD active protein,
correct, sir.
whether it is downgrading or upgrading or it is remaining as a constant.
Sir,
Radiologically, the report comes as pneumonia. So we want to suppose there are 2 CT scans available, and if we want to compare the two, do you
sir.
think this crediblehealth.com helps?
Yeah, absolutely, sir. It will precisely do it, and it will also give a comparison between how the CT severity score was between the two X-ray between the two sequential CT scans. So most definitely, sir, it can do it. The other interesting thing is, sir, that now everyone has become good at reporting COVID X-rays and CT scans. Earlier, when it was a novelty, people were very intrigued that what are the findings and this and that. But now even the radiology community and even, sir, a lot of the pulmonology critical care community has gotten very good at diagnosing it. So as that happens, the value that AI provides starts becoming less technical, sir, and more logistical. Like an instantaneous report. Literally, your CT scan is done right now, and 2 minutes later, you have the report. That is something that in most clinical workflows is not possible. So that's the other nuance, sir, that you have to again,
Now, the
sir,
most important will be to have this software, whosoever is making it, Credible Health,
sir,
interlinked with the CT report of RT-PCR, interlinked with duration of testing,
yes,
interlinked with the clinical IL6, CRP, and ESR,
yes,
and
yes,
interpreting it, then working like a clinician. So if the same data is available, AI technology is available, even from today starts putting the clinical data into it, the machine may give solutions to unexplained people.
no, absolutely, sir,
Like the solidarity trial results have come after 6 months. If
yes,
they would have used AI, the results could have been ready. I mean, after 6 months, you are telling remdesivir is not useful.
sir,
This data,
sir.
I mean, for 6 months, you are.
Sir, but one also has to be, cautious about things. Like we saw how the whole Surgisphere thing played out, na sir. So, and the Surgisphere company itself called itself a AI analytics data company. So there has to be a balance, sir, because, so all the examples I gave, sir, Google Maps, Google search, typing, etc., those are low risk applications, right? If Google Maps, if it takes you through the wrong way to a place, it really doesn't matter that much. So, but in our kind of setup, sir, the implications are also very grave of wrong outcomes or wrong predictions by algorithms. So that's why, sir, it's again, I so essentially, sir, the pitch is that it has to act as a tool. It has to act as a addition to what the clinician does, and not act in isolation, whether as part of a clinical trial or as part of clinical practice, sir.
It is still what I say is that when we say, for example, we have certain predictions now. We have certain predictions now. These predictions have come to us. They should have come to us if I use a biochemical criteria. For example, if you have fever more than 101 or CRP more than 10,
Sir.
you invariably have pneumonia.
Mm-hmm.
Okay, now what I'm trying to say is now this needs a validation. This is not reported anywhere in the world. And for the last over 500 patients, I've yet to find a difference that it is filling into every patient if your fever is more than 101, because it has a low grade fever as far as COVID is concerned. And if your CRP is more than 10, you know that you have pneumonia. Or if you have pneumonia, you can go other way around and say CRP 10 se zyada niklega, and this will be there. So there are many clinical predictions available as on today, which we want it to be put into AI other way around. I mean, this is what we are seeing. Is it correlating things from that? So what I'm trying to say is that if the whole population of IMA gets involved into data feeding, a real good AI can come. So if you can build up a software with IMA, where all the doctors in the country can put up their data, real machine learning can come, and we can come back to the clinical answer for that.
Sir, sir, that we already built that, sir. Believe it or not, we already built that. If you go to covebase.carpal.ai, I will take the liberty of, sir, sharing my screen. Sir, can you see my screen? This one?
Yes, but make it yes, Covebase.
Yeah, covebase.carpal.ai, sir. I will.
Carpal.
Sir, Carpal is the name of our software, actually. I will just. We already created the backend technology, sir, and this was, with Kaho that we had taken this initiative. And again, it was part of that same data sharing initiative, sir, that we had. And literally, if you register and you log in, you can submit your case forms. So you can, your name of the hospital, if you have a designated number, city, nationality, employment, date of first symptom, etc. Then, it goes on to all past history, comorbidities, admission, fever, type of fever, grade of fever, nature, all the clinical parameters you can add, temperature, BP, etc. Everything, sir. And then you go on to add lab test reports. So you first day, what was the test? Pathogen tested. Again, the entire story again, and this time all the lab results you can add. So we had created, sir, this very, very elaborate system. There were volunteers from AIMS that had helped out. But sir, the thing was that we had created this, sir, when COVID was a novelty. And then so quickly the entire country got so busy that we just could not find enough input, and but this exists.
Yes. I want to say one thing is that,
sir,
if you can help us, can we take the slide off?
Sir.
And you give me the spelling.
covebase.carpal.ai.
So what I'm going to end by asking one thing, that IMA would like to collaborate, subject to clearance by the IMA working committee or by the president secretary's meet. we will be interested in collecting the data of 500 deaths of the doctors.
Hurry.
We can
Sure,
collect
sir.
that data of the doctors and put it into the AI system. If we can come back to a common collaborating factor, what was the reason why the doctors died, it can be a
Yes.
great service to the humanity.
Yes.
So I am only proposing it. Secretary General is here, and if this can be done, we, even if you need some people to work onto it, we can arrange funding for that. If you need some people, our team will work at a national level, bring the data from the doctor's home, what the data is required. If we can really come back with some common factor, why did our doctors die? That will
Yes.
be a great service to the IMA. I hand it over
Yes.
to Dr. Ashokan. Dr. Ashokan, you have to unmute. So I took some liberty on behalf of IMA to propose something, but subject to clearance by the national president and the HSC.
Sir, that is your humility that is making you say this. You are a, what can we say? You are a elder in IMA, and you are a statesman who is guiding IMA. So I think such a novel idea which is coming up, I think Indian Medical Association will be with folded hands take up this project, because we are very much concerned about the death of doctors, and IMA is trying to do something for their families also. So something could come out which can help other doctors also to refrain from doing certain things or adopting certain measures which will be useful. And we'll certainly take it up. And I really congratulate Dr. Vidur. This is providing us actually with fourth or fifth dimension of the issue. This is not the in normal our want to understand such things. Only a person like Dr. KK can understand an expert like you and bring it to the view of ordinary lay doctors like us to understand what exactly we are talking about. So it was so interesting. Thank you so much on behalf of Indian Medical Association. May I request our honorary Dr. JK, do you have a query or anything?
Nothing, sir. Nothing, sir. Nothing.
Right.
I have a back-to-back seminar, so Dr. Dutta, to close up.
Yeah, close it up, sir.
Thank you, sir. Sir, on behalf of Indian Medical Association, I'm very thankful to our HSG, Dr. R.V. Ashokan, for organizing this seminar for our members. And at the same time, I'm very, very grateful to Dr. Vidur Mahajan for beautifully elaborating what is an artificial intelligence and its role in COVID-19. So he has given us, made us more intelligent now today by his elaborations, what he has given. At the same time, I am very thankful to our resource person and anchor and my Guruji. He's my Guruji, Dr. KK Agarwal. I am learning so many things from him every time. At the same time, I am thankful to Dr. Jayakishan. And today I see for the first time Dr. GM Singh and Dr. Wadhwa along with us, and Dr. Sanchita for joining us, and the whole staff who is working behind the screen for making this webinar a great success. With these words, I thank you all once again. Thank you very much, sir.
Thank you.
Dr. KK to close the meeting.
That's all for today. We'll be back next Saturday with one more session. Thank you, IMA. Thank you, Dr. Ashokan, and thank you, Vidur, for a wonderful discourse. And this will stay on IMA website forever. Thank you very much.
Thank you. Thank you. Thank you, everyone.